A study presented depicts a 52-year-old male known as Frank who presented to the clinic with pain around the plantar medial calcaneal tubercle. Frank is currently working as a sales consultant. When we were sourcing our material for the assignment, a systematic approach to how it was collected was undertaken. We used the La Trobe University website, access to the La Trobe Library homepage. We then used databases. Within that, areas of health science and podiatry were chosen. From here, a range of databases were revealed. I will highlight how we use one database as an example. If Medline was selected, keywords such as plantar fasciitis were entered and map term to subject heading box selected. When pressing search, other terms that could be used appeared. Appropriate terms to match our search were identified and selected. For example, fasciitis. Alternate spelling, terminology, truncation, phases, and wildcards were now added when necessary. In our search, the possible diagnosis was always included, that is, plantar fasciitis or calcaneal stress fractures, the method of imaging and other terms that suited a specific search, such as sensitivity, specificity, cost, or safety. Variations of each term were identified. After all the words and topics that needed to be searched were identified, they could be combined with or and. From here, each group member could identify what articles could be most appropriately used by assessing the level of evidence of each article.
Differentiating between calcaneal stress fractures and plantar fasciitis can be complicated as localized pain and tenderness to the posterior and/or plantar heel most often represents plantar fasciitis. Both conditions may be associated with extra weight gain, increased activity, changes in career and/or changes in shoe gear. These similarities in symptoms and clinical presentation is why imaging modalities must be used correctly to diagnose a patient, to ensure a treatment plan can be created to alleviate Frank from his pain. So to begin diagnosing the patient's condition, we start by using ultrasound.
With ultrasound, the plantar fascia can easily be differentiated from the superficial fat pad and the underlying calcaneus. The study conducted by Grocia and colleagues determined that the ultrasound findings used in the diagnosis of plantar fasciitis included increased thickness and decreased echogenicity of the plantar fascia. These were constant ultrasound findings in individuals with symptomatic feet compared to asymptomatic feet. The normal thickness of the plantar fascia has been reported to be between 2 and 4 millimeters. With a plantar fasciitis greater than 3.9 millimeters, the sensitivity was 71.4%, whilst the specificity was 74.1%. These findings were supported by a meta-analysis conducted by Millian and colleagues, demonstrating that plantar fascia thickness values of 4 millimeters or more and hyperechogenicity of the proximal plantar fascia can be indicators of plantar fasciitis. The confidence intervals for both plantar fasciitis thickness and hyperechogenicity do not cross the no-effect line, so we can be 95% certain that the true average effect of hyperechogenicity and thickness actually lies in favour of these factors being related and can be used in the diagnosis of plantar fasciitis. The study classified as Level 2 evidence within the NHMRC hierarchy of evidence. Although ultrasound is better suited to soft tissues and diagnosing soft tissue pathologies, it can also be used to help diagnose stress fractures in the foot when already being used for plantar fasciitis. In a study by Bianchi and Luong, they found the sensitivity of doing so is 83% and 76% for specificity, which compared to Bohm and colleagues is only 49%. The positive and negative values calculated by Bohm and colleagues are 41% and 51% respectively. Within the same study, it was stated that this was not a reliable form of imaging, and further tests must be used to confirm the diagnosis of a stress fracture. In comparison to other imaging modalities, the use of ultrasound imaging has been found to be relatively inexpensive, ranging from $130 to $180 or approximately $93 with Medicare rebate, and may be considered to be relatively safe compared to other methods as it uses non-ionizing radiation. This is further supported in a study by Carabay, Turrells and Hurrell, who state that the advantages of ultrasound are that its application is non-invasive and it is highly tolerable, free of radiation and cost-effective.
So here we can see that for a positive result for plantar fasciitis, it would result in treatment or management. A negative result for plantar fasciitis would result in a conservative treatment to manage the symptoms. A positive result for a calcaneal stress fracture would result in early treatment and management, but further testing would be required because of the low specificity. and a negative result for a calcaneal stress fracture would result in further testing. This would then lead us to the use of an MRI.
MRIs are considered to be extremely accurate in the diagnosis of stress fractures with a sensitivity ranging between 86% and 100%, combined with a specificity of 86%. In terms of safety, MRI is non-invasive and uses non-ionizing radiation, making it a safer imaging modality. However, other modalities should be considered if patient suffers from claustrophobia. It is also relatively inexpensive in comparison to other imaging modalities, only costing $290. Medicare rebate is also available if referred to by a specialist. In a study by Dodson and colleagues, no other imaging is as efficient or safe for the patient in diagnosing calcaneal stress fractures as MRIs. Similarly, studies conducted by Patel, Bianchi, and colleagues state that MRI is the gold standard when detecting and diagnosing stress fractures. Another advantage discussed in the Berger study is the ability of an MRI scan to determine a prognosis for stress fractures by grading them into 4 classes. When other modalities fail to confirm a diagnosis for plantar heel pain, an MRI would be the next best option due to its ability to visualize in greater detail the anatomy surrounding the calcaneus. The evidence we found could not be classified according to the NHMRC hierarchy of evidence, as they were all literature reviews discussing evidence ranging from systematic reviews to case series.
If the MRI was unsuccessful in diagnosing either plantar fasciitis or a calcaneal stress fracture, then it's most likely that the plantar fasciitis diagnosis can be discarded, but the calcaneal stress fracture may need further testing to confirm the diagnosis. Bone scan imaging has been found to be useful in the identification and evaluation of plantar fasciitis, with the scans evaluating the specific appearance of delayed uptake at the common calcaneal insertion of the plantar aponeurosis. In a study involving 43 patients with a clinical diagnosis of plantar fasciitis, 45 out of the 58 patients with symptomatic feet and 4 out of the 28 with asymptomatic feet demonstrated a positive predictive value of 91.8%. In 8 patients, however, bone scan revealed other causes of foot pain associated with plantar fasciitis findings. A sensitivity of 75% found for bone scan is similar to that found throughout literature. According to the NHMRC, a study conducted by Kane et al. 2001 was classified as a level 2. It is considered to have a sensitivity of 100% and a high specificity when using a 3-phase bone scan to detect a calcaneal stress fracture, but according to other studies, this number is actually much lower. Despite its potential to provide a sensitive and sometimes non-invasive modality for diagnosing various painful conditions, the ability to detect plantar fasciitis is limited. And furthermore, in a study by Wall and Feller in 2006, it says it lacks the specificity required to detect stress fractures in the ankle or foot. Although it has been the standard of reference in past decades, recent years have brought about a growing consensus of MRI being a superior imaging tool. This is due to the bone scan's use of ionizing radiation and its high associated cost, ranging from $387.80 with a Medicare rebate to $517 without. In saying this, the bone scan uses much less radiation compared to other imaging modalities such as CT. If the bone scan was not effective in diagnosing a calcaneal stress fracture, or the treatment or management didn't work or wasn't effective, then a CT scan should be considered.
CT is regularly used for the evaluation of bone pathology. Gator and colleagues have acknowledged CT scans as having 42% sensitivity and 100% specificity. Some of the general advantages of CT scans are that they provide 3-dimensional reconstructions of segments. This is useful for complex fractures as it provides fine osseous detail. CTs can image multiple angles and can analyze slices which can vary in thickness. A thin slice, multi-section CT has shown promise but remains inferior to other modalities such as scintigraphy and MRI. Some of the general disadvantages of CT include that they are not used for soft tissue pathologies and it uses a high dose of ionizing radiation compared to other imaging modalities. Therefore, there is an increased potential to cause harm to the individual. CT is also more difficult to access. In terms of the cost, CT has found to be relatively expensive.
It ranges from approximately $280 to $317. However, with the Medicare rebate, it could reduce to $187. The fact that it will not be used to identify other suspected pathologies such as plantar fasciitis, the sensitivity of calcaneal stress fracture imaging is low. Alongside the cost and the amount of radiation, this imaging modality would not be of high preference compared to the others that we have talked about today.
A positive result for calcaneal stress fracture confirms the differential diagnosis and would lead on to treatment. If the result was negative, then both plantar fasciitis and calcaneal stress fractures can be discarded, especially if they were negative for other tests. Then this would lead us to diagnosing another bone pathology such as a tumour, and more testing would be likely. Taking into account Frank's signs and symptoms, we applied this knowledge to researching the modalities available to help conclude his diagnosis. We found similar evidence throughout the literature and concluded that this was the best pathway to take in diagnosing our patient with as little risk possible.